Hello, everyone. Thanks for being here tonight. My name is Nicole Bell. I'm the Executive Director of the Cambia Grove. And I always talk a little bit about what is Cambia Grove because we're always seeing new faces here. And also, we're always live streaming now. And so from the vast interwebs, we want to make sure that we're appropriately welcoming any new faces, whether they're actually physically here or online. So what the Cambia Grove is, it is Seattle's healthcare innovation hub. We serve the larger Pacific Northwest, and our mission is to create a perfect mashup of today's healthcare leaders with tomorrow's next generation thinkers so that we can become the destination, the national destination for the next generation's healthcare solutions. And so it's my honor and privilege tonight to introduce Lee Huntsman, who is the MC for our program. And I'll leave it at that. Lee, come on board.
Thank you, Nicole. You know, she very carefully avoided the question of whether I'm a thinker or an innovator. And the truth is, I'm just an old guy that is really interested in the changes underway in healthcare and the significance of those changes for all of us that are in or aspire to be in what I call the innovation ecosystem. So we're thrilled to have two contemporary experts from the front lines of American healthcare with us tonight to talk about what's going on. So, gentlemen, please come forward. First, let me introduce Dr. Phil Colmenares from Premera. He's a senior vice president and chief medical officer, which, as I recall, is a license to do whatever you want, but I'm not sure about that. He'll straighten us out. And David McCune, colonel in the U.S. Army and part of Madigan Hospital, which I have always regarded as one of the unrecognized enormous assets of our region. And so I'm sure you'll tell us more about that. But gentlemen, thank you. Please sit down and make yourselves comfortable. You know, our purpose in Under the Boughs is to hear different perspectives and then reflect on, as I said, what's the significance of what's going on? How do we interpret the chaos that you could ascribe to American healthcare today, and how does that mean we innovators need to change our thinking, our approach, and our expectations? So tonight, what we want to do is to get a lens on contemporary civilian healthcare, which Premera certainly knows as much about that as anybody, and a lens on the military medical system. The principle being that those two systems both have a lot of history, but they operate differently, and particularly they operate differently in their financing. How is care paid for? What is the significance of that? Because as you know, the thing that's driving so much of the conversation these days is the move from fee-for-service toward a value-based approach. And arguably, that should not be as mysterious as it seems, because there's case studies out there of operating differently. So, gentlemen, thank you for being here. Maybe before we start, tell us a little bit about who you are, how you come to be in the position you're in. David, want to start?
Sure, thank you. And first, thanks to Nicole for inviting me here, and Lee for hosting. It's really my great pleasure and honor to talk a little bit about the U.S. Army healthcare system and the DoD healthcare system in general. I would begin my remarks by saying I am speaking for myself. These opinions are my own. They don't represent Department of Defense policy or the policy of my immediate superior officers. So we always have to say that.
Which is just as well because the Department of Defense policy will change tomorrow anyway. So.
Yeah. Now, if they would listen to me, they would be. But anyway,
all right.
That's another story. So So my story is briefly. I came to this as a healthcare provider. So internal medicine, going on to hematology oncology, and hematology oncology has kind of a culture of doing clinical trials, and so in the clinical trials are looking at drugs and patients' responses, and that was sort of where I first started dabbling in clinical research. And I kind of leveraged that over time, shifting more and more from not being full-time practice to working within the Army's clinical research community. And long story short, the last couple of years I've done this job called research consultant for the Army's Regional Health Command Pacific, which is the kind of the parent organization for all of the healthcare in the Pacific Coast and kind of the Pacific Rim. So a really large group with a really broad mandate. And the reason I went there to do that was because we have a lot of missions, and my opinion has always been that research and innovation could fuel those missions and help succeed in those, but research never appeared in any of our strategy plans. And so the idea was I would go there and work with them to try and find ways to use the research program as a vehicle to establish things like our main missions, which is to improve the readiness of the healthcare, readiness of the soldiers, improve the readiness of the healthcare delivery force, meaning the doctors and nurses and other care providers. And the final piece was what we call medical diplomacy, which is just kind of getting the word out about good things that the Army is doing that don't involve shooting people and breaking things. So those broadly have been what we've been trying to do. And what we find is that there's a lot of ways in which what we do intersects with what you do. And that's what I'm here to try and explain and talk about and put out some ideas. So thank you.
Terrific. Phil, how did you get to this point?
Yes, hi everybody. Thanks for the invite. The way I got here is Dr. Espinola, my boss, was going to speak, and he had a conflict, and he does send his regrets, and he sent me. I am a retired commander in the U.S. Navy, and he told me to keep the banter down between the Army and the Navy. So I don't have to say the little blurb that David had to say, but please don't tell my boss what I say today. Three flavors of sort of healthcare that I've had in my journey through life is, number one, 24 years ago, in the span of 1 month, I got married. I moved to a very rainy area of the country called Bremerton, Washington, and was stationed out of there on a nuclear-guided missile cruiser. I had to fly all the way to Hong Kong in that same month to find the ship, and then I was also the radiation health officer. And then I went through a 20-year career in the Navy there, although just 11 to 12 years active duty. So I got a flavor of the military medical system there. In addition, I'm first generation American from Colombia, South America, and in that same year, the Colombian system went to essentially what Obamacare ended up being, but with a public option. So over the last 20 years, 24 years, I've kind of seen what the Colombian system has transformed to, and sometimes had to protect my mother against some of the medical care there. And we'll probably talk a little bit about, what innovation is and how sometimes we overdo things. And then the last 10 years, I've worked in the health plan area. After the Navy, I went to Madison, Wisconsin, and I've been here 8 months, and I came from Madison, Wisconsin. I worked at a clinic called Dean Clinic, which is a provider-owned system that has a health plan, but it doesn't have a hospital. So the only way, really, it makes money, because most clinics in the country don't make a lot of money, they either have to have a hospital or a health plan. The physicians in the group basically took off their clinical hat, and that's what I did, and then I'd go over to the health plan and then say no to my colleagues when they wanted to order something or do something that really just didn't meet the criteria. So I kind of got a sense of how, in those days, 10 years ago, a provider system did value, which is basically kind of compartmentalizing. One day you're in the clinic, the next day you're in the health plan. But very happy to be here, and Primera is an extraordinary organization. Really happy to be working there.
Well, that's a good segue. David, Phil, tell us a little bit about the nature of your organization. What do you do? What's the span of function? And what's the degree of continuity versus change? What's the climate like?
So the Department of Defense has the military healthcare system, and that's the largest parent organization. And then within that, the Army Medical Department operates. It's a really large organization. If you look at TRICARE, our version of insurance, it's got about 9 million members in it. So really large, a lot of missions nested within that. So the one of the things that's interesting about the Army as your single provider for your healthcare is it's also the employer, and it's also sometimes the landlord. So you've got this whole soup to nuts of people inhabiting our healthcare system. So we have public health missions, we have wellness missions, we have pediatric on through geriatric. So it's a really large healthcare organization that's also the payer. As you might imagine, that and it's interesting, and I was just telling Lee, as we were having the run-up to the discussion about the Affordable Care Act, it kind of struck me as somewhat surprising that there was so little reference to what was going on within our system. As you talk about a public option, and you talk about single payer, and you talk about these different degrees to which the government entities are going to be involved in how healthcare gets paid for and how it gets delivered, we've had this kind of ongoing trial within the country for decades, which is the military healthcare system. And so we have this system. It's got a lot of bureaucracy to it. It's got a lot of ways in which it lets me as a provider deliver care without having to worry necessarily about the cost to the patient. It's got these advantages and disadvantages, and I think that's part of what I want to talk about tonight is what we can learn from that, and in particular how the large and kind of cumbersome nature of its bureaucracy can be a retardant to innovation, and how do you focus on that? How do you approach an organization like that with a bright idea? So it can be challenging, and it tends to resist innovation, but I think that there are ways that we can say if you add value in the right way, you can innovate within that system.
Phil, tell us about Premera. I mean, we used to call you an insurance company. My impression is insurance is only one part of what Premera does these days. Is that right? What is it?
Yeah. So Premera has 2.2 million members in Washington, Alaska, and it's the Blue Cross plan in the area. And to your point, I mean, it still is a health insurance company, but what really attracted me to it is about 2 years ago, Premera and the leadership decided to try a new mission statement and a new commitment. And the commitment is to make healthcare work better, which is a pretty bold statement for a traditional health insurance company. But it does have some unique leadership, and the goal is to take the patient's perspective and try to figure out how do we solve for what we all know is a broken system. And the 4 pillars are, from the patient's perspective, are I sometimes get what I don't need, and that's overuse. I sometimes don't get what I need, that's underuse. It costs too much, and the patient experience isn't what I wish it would be. So those are the 4 pillars that we're trying to focus on, and really it's what attracted me to it. I don't know if it's going to be a successful journey, but I definitely want to go along for the ride.
Is there a sense of knowing directions, or inside of Premera and the leadership there, is there a feeling that you can kind of see how the system's going to evolve and how to adapt, or is the anxiety, which appears to me to pervade so much of healthcare today, is that a big part of what goes on inside an organization like Premera?
Yeah, you can definitely see the change going on, but it's, to use a Navy analogy, I'm not going to use Army analogies, it's like an aircraft carrier. It takes a while to steer away. One example is Alaska Air had a customer experience senior vice president, and he also worked at Amazon and other areas, and we brought him to Premera to kind of lead the effort of how do we get the patient's voice and the patient experience to be front and center of what we do. And as we know, health insurance companies are the worst, at making it simple and easy and making it clear. So it's going to be a long slog, because one thing I'd say is the industry has been so focused traditionally on operational things. How do you pay a claim? How do you do prior auth? And just execute on that without a lot of attention to what Amazon gives attention to and others give attention to. So I think I think part of the culture here and just having these sort of events, I think is a testament to having sort of the ecosystem necessary to have a health insurance company try to go down this journey.
So it feels to me like the really gigantic force operating in American healthcare today, I mean, the Affordable Care Act is an important piece and the politics are all important, but it feels like behind that and more significant than all that is the fundamental shift to how we want to pay for healthcare. And that the elephant in the room, if you will, is that over the last 25 years, employers have shifted very strongly towards self-insurance, and now they're starting to throw their economic weight around, and that's underneath this shift from fee-for-service toward value. Does that make sense? Do you think the military system has something to teach us in terms of how to think differently regarding how to provide health care when it's not a fee-for-service system?
I think the things that I would say is the biggest challenge is aligning the incentives with doing the right thing. And when you have fee-for-service, for all of its flaws, you tend to get return on value for what you put into it. So you could say, well, someone maybe is doing too many of a certain procedure, and that's one of the excesses and one of the challenges with fee-for-service. But in general, you provide care as a physician, you get paid, and it's a transactional nature. When you move to an employer run service, or in the Army's case, where the Army is both employer and insurer, those incentives don't really work well. And what you find are pockets of really awful inefficiency, because that's where the incentives drive it. If your incentive is, and not to put too fine a point on it, but if you get paid regardless of whether you do procedures, then even someone who's got a great moral character is going to kind of be drawn to say, well, what's really my incentive to stay till 8 o'clock at night doing these procedures? It's a challenging system that when you set up the incentives in such a way that you drive it toward inefficiency. And I think that's one of the things that you'll continually see is a pocket of inefficiency develops, it gets recognized, and you sort of have to have a top-down approach to addressing it. Well, you must meet this, metric of output to be considered successful. So it ends up trying to sort of mimic some of the virtues of fee-for-service, but it doesn't do it organically. And I think that's one of the real challenges as we move to this, is to say, can you first identify these incentives, figure out where they are, and are they aligned? Are you getting something? Does everyone within the system, and it applies to the patient too, do you get something good for doing the right thing, or do you get rewarded for doing the wrong thing, or not get punished, or get punished for doing the right thing? Those are the challenges that continually crop up in this kind of system. And as innovators, I think you need to say, well, can I help? It may be what I do, before you sort of look at the value of the innovation kind of in a vacuum, look at it from the workflow and the incentive structure that you're trying to insert it into.
Okay, Phil, what's
I
going
would
on
say
in your domain?
I would say yes to your question. Employers are pushing for this, and we've boiled it down to two things. One is they want lower costs, and that is the higher priority. And then two is they want a better patient experience. And part of the patient experience from the health plan perspective is they want simple and easy, because they don't see simple and easy in the health insurance industry. So that's from the employer perspective. My own personal view is, I think the bigger elephant in the room is, why do you need insurance companies to begin with? So the question is, can you achieve more aligned incentives with a single payer plan? And then what's the reason we don't? And that's the way, from my perspective, it's because of I think in this country, the market takes a little bit more precedence over the right to health care, whereas in other countries, they're willing to overcome that attachment to market solutions, and they put primacy on the right to health care. So the question in my mind is, how much can you accomplish if you keep the market in there and don't have a single payer? I'm pretty impressed, to be quite honest, with the solution that ACA came up with, and I think a lot of it is because it came out of Dartmouth and all the work that Dr. Wenberg has done there. And I do think that it's aligned incentives more, and it's created an environment of healthcare transformation that I personally was skeptical of. I didn't think payment reform could push healthcare transformation, but I do think we've all seen that it has to some degree. Now the question is, how far has it really gone?
Okay, so expand on that a little bit, because well, you guys are both talking about incentives, and of course there's a variety of incentives, but there's no question that financial incentives are one of the big sets. Are those starting to change? I mean, who has a financial incentive to do things differently? You know, from a distant point of view, it would seem like, in a macroscopic sense, the only people that in a financial incentive are the people who are writing the checks. And that's not really the insurance companies, and it's not really the patients. It's the employers and government at all levels, the people who are actually, am I right about, is at root this about the people who are writing the checks are starting to throw their financial weight around and insist on change? Is that going on? And is it also true when you're drinking from the federal hose? We know historically that there's a capriciousness in terms of what Congress decides to fund, at least for the VA. I don't know what it's like for the military system. What are the pressures driving each of your systems?
So the pressures driving us is that half of care in the United States is paid for by the government, either federal, state, or local, but the other half is paid by households or private business. And actually 30% is paid by households.
Oh, really? Oh.
And then 20% by private business, and we feel a lot of that pressure because they just have a stronger voice because they're more united. But the higher deductible health plans and the continual increases in costs above CPI, which has been eroding middle class wages, I think all that puts a pressure on both those things, both cost and patient experience. Now, to get a little deeper into your question, my own personal opinion is that the underlying thermodynamics of the healthcare system has not changed. The business model is the same. There is, on the surface, more movement to ACOs and bundles and more talk of value. But I guess I'm a little bit of a naysayer in that I don't see the complete switchover. I don't think the hospitals have had the courage or the inclination to make the move. Maybe there hasn't been enough impetus in the system, but my own personal opinion is there has been change, to answer your question, but the underlying business model is still the same.
Okay, I want to come back to the impact on how care is actually delivered, but how does the financial pressure feel inside the
So
military
you may
system?
have tracked that the National Defense Authorization Act was, there were a lot of changes reported in it. One of the biggest is a move for the supervision of the Army's medical department to go under this larger entity in that's kind of based in the national capital area called the Defense Health Agency. A lot of us kind of at the ground level feel like that's a layer of bureaucracy, but it was a direct result of the impression that costs were out of line with the value being returned.
Oh.
And that's one of the challenges in a system like ours is, you know, to take kind of the ground level doctor view, I would say, well, you gave me, you know, this set of resources and asked for this set of outputs. Those weren't matched well, and my civilian counterparts had a different set of assets, and to judge me by that standard is you're gonna always see me falling short of that. The senior level response would be, well, you said you could do it, and now you're not. And so because you kind of, because the gap between the customer and let me back it up. We had this this episode where we were talking about applying for a Boughs Award at our hospital, and the foundational discussion was it's a customer service award, and it was who's our customer, and we had the really long discussion about, well, who is our customer? Mm-hmm. Is it the patient? That's what your typical hospital, you'd think, well, your hospital, your customer is the patient. I was like, well, is it the people that work there? Is it the federal government? And actually the whole thing literally fell apart because we couldn't figure out really who is, at the end of the day, is our customer. And that's one of the challenges that we continually run into is, do we try and add value to the federal government and return, lower cost and for the same amount of health care, or do we try and deliver the absolute best patient care to a patient? We talk about the patient experience, and we survey our patients, and we pay our hospitals back based on the response survey data they get, but it's a pretty clunky mechanism for incorporating essentially patient choice in a system where their choices are highly constrained by the fact that it's a single payer. So we struggle with this. Are we giving value? Is it closer to being right where the provider says, I'm not given the tools to do the job of being asked to do, or is the federal government right in saying that this is an inefficient system and you need to have different management? So we struggle with that.
So let's talk about, okay, we got a lot of financial pressures and dilemmas and who knows how much real change. But what effect is that having in both how healthcare is provided and how people responsible for healthcare think? I'm really struck by your question of, we had a big debate about who our customer is and we couldn't decide. That seems to me a really telling story.
It was.
And but what's really going on out there? Because sometimes it feels like, at least in the civilian system, what healthcare organizations are doing is upcharging everywhere they can and putting money in the bank in order to have a balm for their insecurities. And other times it feels like a very high fraction of people are hoping this whole thing will slow down so they can retire before it gets any more messy than it is already. And there's just all this. So is there a change in thinking? Is there a change in practice? How dynamic is it really? Phil, you were asserting that maybe down in the bilge, this ship isn't that different.
Right, so I'm going to say something paradoxical. I definitely think there's been a lot of change.
Oh.
But I just want to emphasize that I don't think the underlying business model has changed. But
Okay.
In the last 10 years, I've seen significant change. There's, like I said, I was surprised because I was skeptical that payment reform would induce a lot of provider systems to do clinical transformation or healthcare transformation, but they have, and now they're talking about value and they're talking about the patient experience. But I think two limitations to it is one is physician burnout, the change fatigue, and everyone has change fatigue. We have it in the insurance industry, but I think that limits how much you can do. And then the other is the history of the 90s when a lot of provider systems took on downside risk and went bankrupt. And so I think because the underlying business model doesn't want to go through that again, that's where you get the pullback, and there's a lot more interest in bundles and dipping your toe into value but not going all in.
Would you say though that, because if you look at the Affordable Care Act and like when people start talking about let's break off this or that piece, but the most popular pieces are probably the pre-existing condition and kids up to age 26. And if you sort of say those are the third rails of this act that are unlikely to change, to me that says that really we're not likely to go back. But you're immersed in this, so that's kind of my thinking is that we're not going back to the fee-for-service, like the path back to where we were. I think the sea change has been in people's expectation and, frankly, willingness to kind of pool ourselves into larger and larger entities. Do you see that Or do you think
Yeah.
that there's dissatisfaction with that?
No, I agree. I don't think we're going back. But I think the point I'm trying to make is if you don't do single payer, then there's a limitation to how far you can get. And so I think there will continue to be the movement towards value at a slow pace, and it'll be positive change. But I think we have to ask ourselves, how far can that go if you don't change the underlying system?
This seminar series in its various forms has been going on for 3 or 4 years now, and one of our early speakers was a senior executive in a big health integrated system. And he stood in front of the audience and he said, you know, I have to confess that we in healthcare don't understand our costs. And you know, here it is, the largest industry in the American economy doesn't understand its costs. Is that right? And is that, and beginning to understand costs and try to optimize for costs, is that part of this fundamental shift that you think is going to persist kind of independent of the politics?
I would say that I'd like to actually try and keep a little bit of that lack of awareness. And so one of the virtues of my system is to a large degree, not completely, but to a large degree, I can make decisions based on clinical indications.
Right.
And that's something that is just in the core DNA of a lot of providers is to be on the patient team. And so we start dividing up we sort of started picking teams. You've got the payer, you've got the hospital, you've got the doc and the nurse, you've got the patient. One of the challenges with going to these accountable care models is you start to take the providers and put them on the side of the payers.
Yeah.
And
Yeah.
I really think we need to try and find as many ways as possible to resist that, because that the patient knows eventually, maybe not individually, but corporately, our patients will know, and it won't be a satisfying system in which to work. And once it becomes an unsatisfying system, there are a lot of negative ripple effects that come from that. So as we look at this, I think that, do you want providers to be ignorant of cost? No. You want them to manage responsibly. But I think it's good to have that management a little bit top down, you know, to say, here are some constraints, some lanes you operate under, and then go do the best doctoring you can. That's what my takeaway from our system is, I think it works best when it's like that. And I think you get the highest job satisfaction and patient responses when they don't feel like their provider is checking a cost sheet to be sure that they're staying within a range. Does that make sense?
Yeah. And
So let me answer on 2 levels. On the one level, I agree that there's a lot of opacity to cost, and there's a need for more transparency, and there's too much variability, and there's no good reason for it. But at a macro level, I think it's worth looking, and for our discussion on innovation, looking to how countries spend money on healthcare and social services. So the U.S., in general, it's a pretty standard percentage, and I forget if it's 21 or 20%. Ours is 18% on the medical system and 2 or 3% on social services. That might be wrong, but essentially, if you add those 2 figures, most countries spend about the same amount of money. We just bias it towards the medical system. And what are we getting for it? We're pretty close to last compared to other countries on measures of health and wellness. So we got a very costly system. So there's 5 cost drivers. 1 are the health insurance companies, 2 are the doctors, 3 are the hospitals, 4 is pharma, and 5 is the biotech industry. So if you go to single payer, let's say, and you do away with that part, what I'm telling you is that's not going to solve your cost problem. You're still going to be spending close to 18% on, so you're going to have to address the other 4. So let's put the docs aside and focus on the hospitals, the pharma, and the biotech industry. So the hospitals, their margins are way above CPI, and there's different ways to try to address it, but basically you have to confront the issue. And then pharma and biotech, when you have a system that's very market-based and has a very loose definition of what innovation is, and just allows a lot more into the system than we can really afford, then I think you're going to have a problem. So until we are willing to talk about those things and face them, I think the costs are just going to continue no matter what you do with the health insurance industry.
So let's spring off of that to the question of innovation in each of your systems. Is innovation needed? Is the needed innovation different than what it has been traditionally in light of these new pressures and so forth? What can innovators do to be constructive?
So my thoughts on it have to do with a couple of times that we've introduced research projects that appear on the surface to be highly innovative, and it's not hard at all to say, and you imagine that the company at some point said, here's our value proposition, you're paying X for this, now you're going to pay X minus Y. Seems really cut and dried. But without integrating it into the workflow and without having a knowledge of how the overall workflow plays back into the structure of how dollars come to the hospital, it's the technology adoption curve is not the typical, your early innovators and then everyone takes it on and then it's just, everyone else is coming in to make it 100%. People will resist changes if they're even mildly impactful in their workflow. And that's one of the challenges with this system, is because this push toward value has really squeezed, I think, a lot of the play out of the system in terms of the typical doctor-patient healthcare visit, that the innovator has to recognize and work with people in that space to say, where do I fit into their workflow? If it's an IT innovation, is it 2 clicks too many and the person's just not going to adopt my widget into their workflow? Those are things that I think that innovators have in the past perhaps been able to say, we'll work that out after we get the tech developed. And I'm saying that they're actually foundational to what you're trying to do. If you haven't answered the adoption question and how it's going to fit into both the workflow and the payment model, then you may be investing your time and effort in something that has no chance. And so that's what I would say, is that I've seen things that looked like great ideas not get adopted for what seemed like trivial reasons, but just because they seem like trivial reasons doesn't mean that that's not baked into our current system.
That's an interesting challenge. What do you think, Phil?
I approach innovation the way you do a differential diagnosis. So as a physician, you come up with a list of, let's say, 20 diagnoses, and you continually hit it up against the patient and ask more questions, do more tests, and you slowly get to what the diagnosis is, hopefully. And hopefully it's the right one. Now, the same thing with innovation. Let's just say there's 100 units of new stuff out there, so you produce new stuff. Then you need to know it's safe, and so then you have the FDA try to say whether it's safe, and let's say out of the 100 units, 95 of them end up being safe because most developers are pretty good at knowing that they have to pass the safety standard. And that's kind of what gets thrown out in the current market, but then there's efficacy and effectiveness. So efficacy is it better than a water pill, a sugar pill, or is it better than nothing? And maybe 50 of them are better than nothing or better than a water pill. And then you want to know, is it better than what's currently available? And that's comparative effectiveness or a good health technology assessment approach, which we don't have at the federal level, but we do have it at the state level. And then the last question, which we don't really do anywhere in this country, is cost-effective analysis. Is it better, but is it worthwhile better? Is it worth the price? Is the marginal benefit better? And that is a true innovation. And it's probably about 5% of the 100 units. And I don't feel that we have a good definition here to define that innovation and drive it towards that 5%. It's being driven in a too much of a dispersed fashion.
So we got an audience of innovators. What's your advice to innovators? Would you say, yeah, bet on the changes and innovate around prevention? Now, historically, this system's been very poor at paying for prevention, but that's going to change. Or would you say, table the technology and go study the real world and make sure you understand workflow and the things associated with it before you even start? Or would you say, don't even contemplate a product that won't demonstrably reduce costs? What kinds of generic advice would you give in this context of change, pressures, uncertainties? What's an innovator to do?
Go ahead.
So I feel that the problem isn't with the innovators, it's with the oversight of the innovators. So we need innovation and that engine to keep going. But what I would say is the question, what is it you're looking for with innovation? Are you looking for monetary reward? If so, this is the great system for that. But if you're trying to also try to move the ball further in the value scheme, then I'd say try to go to the sites of care where there's actual change happen. They're putting in lean approaches and trying to improve their processes, which looks like a number of ways. VM is doing it, Everett Clinic is doing it, Dean was doing it, and kind of just live in that space. And if there's anybody I would live with, it'd be the primary care doctors, the pharmacists, the nurses, and see what they're having to deal with and why they're burning out. And if there's innovation that can help them, the problem is it's usually not as snazzy as the new surgical tool that you can have computerized and a new robot, but it really will move the ball further as far as the new value paradigm.
So I was going to do just a quick survey, and this audience probably knows this. How many have heard of an OODA loop? What? An OODA loop. So OODA is, who knows where it comes from? Colonel Boyd. Okay, do you want to? Here, take that. No, but the story is, why were U.S. fighter pilots effective in, I think it was Korea, right? Was it Korea? I think, and so the thinking was, and what that came out of this is, OODA is observe, orient, decide, act. And what they decided was that the U.S. pilots were just better, didn't have better tech, but were better decision makers in the moment. And what my advice would be, and it builds on what you're saying, is that I think a lot of times we get into sort of decide, act, and you get really caught up in what your innovation is, and you can it's clearly obvious to you that this is going to be a great thing, and it probably is. The challenge is that I think, and I run into companies that seem to have not done enough of the OO. So the observe orient is get out, take your idea at the earliest possible stage to people to give you some feedback, and try. It can usually be low cost feedback. It doesn't have to be necessarily immersing yourself for a long time, but to figure out who's going to use this, and what incentive structure are they working under? Would it mean something to their practice? If you can shave 1 minute off of the time it takes me to write a clinic note, I will kiss your feet and adopt your tech in a heartbeat, because that's the pain point. And if you don't know the pain point of the people that you're trying to innovate for, you run the risk of creating an innovation with no market. And so the more times you can run your OODA loop in your innovation of take some observations, you figure out where it fits in, am I in the right track, make decisions, iterate your product, that's the act, and then take it back. I think that's one of the lessons that I would say is I've run into too many times that I think people haven't gotten that feedback early and maybe have gone down a rabbit hole that ends up being wasted time, that may end up even compromising the ability to take a good innovation all the way to the end. So we talk about the valley of death, and that's the most common way this is put, but I really think it's more about getting as many observations and course corrections so that you can take it to the correct spot and map it to the value within the current system.
Terrific. We got a new acronym besides, huh? All right. Let's remember OODA. There'll be a test next month. Gentlemen, this is stimulating. Let's seize the moment here and ask the audience for questions.
I'd love to ask your two systems, what sort of data has been compared between a fixed model, employee base, all the different things we describe versus our current fee-for-service system in terms of dollars per member per month for delivering care or administrating care? Do we have that comparative data?
Well, that data is what led to the National Defense Authorization Act changing the leadership, or changing the supervision structure. But it's a little bit apples to oranges, because when I talked about our missions, our biggest mission of readiness doesn't necessarily have a strong analog in the civilian system. You know, you're not getting employees ready to go to war, and we are. And so there are costs in our system that make the challenge not exactly apt. But I think we can say that over time, there's been a perception that our system does not produce the number of patient encounters per provider that a comparable civilian system would for the amount of money. So I think our system struggles with things like that in terms of generating the more traditional value metrics, and we try and layer over that things like, are you meeting certain national benchmarks with respect to preventative care and things like that. So we try and layer these other means of measuring value in our system, and we do better in that.
One specific one. For example, back surgeries or arthroscopies. In that space, there's a lot of data that says that we're incentivized to do too much. And your system would disincentivize that. Do we have comparative data in those types of procedures?
I don't have that. Do you?
I must be dense. Could you repeat the question? I'm trying to understand.
Spinal fusion surgeries, for example, here in the state, Washington State, LNI, doesn't pay for them very much. Very, very restricted. Arthroscopies, you hurt, let me look in your joint, but studies have shown that's not effective. So there's a lot of effectiveness data where the financial incentive is still there to do more, and is there a year ago, 10 years ago, and it's still here today. The military system should be a system which would not incentivize that, except for consumer demand, which is clearly there. And I'm just wondering where we can find those types of isolated procedural comparators, whether we have comparative data.
No, and I don't know if this answers your question, but so bundles is a way to try to limit that incentive, and so is downside upside risk, like an ACO, where you're pushing the system to find areas where they can stop spending so much and make up the money. But I don't know, I guess I'm not understanding the comparative data part.
It would be per member per month.
Yeah.
1,000 people, 100,000 in your plan, 100,000 in yours.
Oh, I see.
We have
Between the military and the
absolute
commercial.
numbers of those procedures. And if not, I think that would be a
Yeah,
single
I'm not aware of it,
that
but
I'd love to know between the systems.
Yeah, I'm not aware of a direct comparison. Those data exist, so the comparison could be made.
In principle, there ought to be comparison studies between the U.S. and other.
is your thought that there probably is a pattern of decreased utilization in the military, or?
I would hope so.
Yeah.
As with other countries, I would hope so. But we've got it in-house here because we are a society with a lot of consuming. The consumer demand may flow right across,
That would be fascinating, because I'm not sure there is in general, because having worked in the military system, I didn't see a lot of dampening down on specialist procedures, although I've been out of it for 10 years and I don't know if there's systems in place now, but I saw them practicing similarly to the way they practice commercially, but I might be, the data would tell us.
I would, my gut tells me a little bit less, but in general, it tends to mirror whatever the clinical practice is in the community that surrounds it.
Other questions? Yes, sir.
Hi, I'm Bruce Smith. I'm the medical director here at Regents, but for 8 years I worked at Group Health, which is similar to a military system in that they are fully capitated and they're paid to keep people well and not just to do more stuff. And the logic at Group Health had always been, and Kaiser, because they work very closely together, and in fact, in another 2 weeks they will be together. The idea was that the fully integrated capitated system ought to be about 10% more efficient than the fee-for-service model. Operationally, it's challenging to pull that off, it turns out. But they're probably more comparable in a commercial fee-for-service model versus an HMO model than it is the civilian market versus the military. health system because they have different incentives. But group health in general and Kaiser both, and other HMO style systems end up coming in at about the same price point as most commercial health plans currently, even though in theory, internally at group health and Kaiser, they believe they ought to be able to do it for about 10% less.
Yeah, that's one of the great puzzles, isn't it? Why we got case studies out there, right? We got a mammoth one called Kaiser, and why isn't it 10 or 15% less expensive? So, all right, other questions? Yes, sir.
Just a reminder, if you can give me a chance to
Oh.
give you the microphone when you have a question, that way the people on the live stream can hear you.
Great, David.
Thank you. I want to go back to one of the comments, Phil, you made. Why do we need health insurance? And if you look at how health insurance operates, it's very different from how car insurance and other insurance operates, which is you collectivize risk, you call on insurance when something really goes bad, right? And many countries have a system where they take care of the basic sort of coverage for primary care, catastrophic coverage, that's national, and then in between, if you want something, you basically have to pay for it. So what's your prognosis of the healthcare insurance industry in the long run? Why is it mediating healthcare? Because frankly, I find it very difficult to take seriously any claims that health insurance is trying to be consumer friendly, because their interests are completely adversarial. So how is that going to work out? It's open to question. And then the second thing, and maybe this is what you were alluding to earlier, I think fundamentally, until we revisit the assumption that healthcare, the way it's practiced in the US, is about, it's about making money. If you don't take that, and we have actually compromised the market too, so we are not a true marketplace. Medicare Part D prevents, government agencies from collective bargaining. Which other marketplace prevents volume discounting? And we have essentially disabled that. So we've kind of messed it up because it's really about making money and not about providing a social service. So reaction, comments?
Well, I would just go back. I think as long as there's this attachment to a market approach, I see it difficult to do away with commercial health insurance or the business model that you describe. I do see consolidation in both the provider side and in the health insurance side. So there is a question of whether the nonprofit health plans like the Blue Crosses, Blue Shields can survive in the long term, and if it's just going to be the top 3 or 4 for-profit health insurance companies. So that is something that our industry struggles with, especially those of us who aren't in that realm. And then on the provider side, in preparation for the ACA, there's a lot of market consolidation, which is still ongoing, and the research shows that any claim that it results in better integration and therefore better care is completely overshadowed by the fact that it just raises prices. So there might be some integration, but oftentimes there's not. It's kind of a roll of the dice, but what is always true is they gain stronger market share and they can get higher prices.
Yeah, pricing power is a big deal. Other questions? David, thank you.
Good evening. So when somebody thinks they have a great idea, how do they get to you to elevate that and see if it interests you? What are the advantages? What resources do your organizations bring that allows somebody, whether it be academia, whether it be a small business that says, I think I've solved world hunger, would you consider this? What can they do with your organizations to try that out?
Well, I think we'll probably have pretty different answers on this. My answer would be, so assuming you've done what I suggested, which is you've kind of got at least a preliminary idea of where it fits into my workflow or one of my colleagues' workflow, then that's where our system has what I think is a lot of untapped potential. And that's kind of been, when I described my mission of over the past couple of years, I've been trying to find ways to say, hey, look, Army, you have these strategic goals that benefit by interacting with innovators. And our system has sort of its own way of doing it, which is we get together some really smart people, they identify a need, they get the resources for it and put out calls for proposals, and you apply for a grant through a broad agency announcement. And it's a really protracted process that can result in really substantial grants 6 to 18 months down the road. So not really fitting in with the idea of, hey, I'm a young, hungry innovator. And the DoD, has anyone heard of DIUX? This is another quiz part of the all right, so DIUX was it was an innovation of the current Secretary Carter, the current Defense Secretary. It stands for Defense Innovation Unit Experimental. And the idea was to apply startup principles to DoD innovation and procurement because we recognize that this is not our strength. It's got bases in San Francisco and in Boston and most recently down in Austin, Texas. And I've done some interactions with them, and it's got a lot of promise, and I'm certainly hopeful that outreach like that will help DoD embrace this. But the truth of the matter is that we have this really long, protracted procurement process. So what I do, so the answer around here would be, give me a call, and I will try and find someone to informally meet. Because I think and that's the key, and it doesn't have to be with DoD. It could be with really anyone that is accessible to you that you think, hey, my innovation maps into your space, and get feedback. So that would be the first step. And then you've got that, so that's your first OODA loop of feedback from the target. And then it's try and find out, is one of these pockets of value willing to take this on? And can you get a grant to fund it? Can you get some other funding source to pay for it? And this is what I said, there's untapped potential, and this is the challenge, is getting that potential from, so the way I describe it sometimes is, if you said, what's the hard part? Well, the hard part is getting a national system of 9 million people under health care, hospitals scattered all across the country, subject matter experts in the field. That's all there. What should be the easy part is finding ways to interact, but that's where we kind of fall apart. And finding a way to design the least, it's not quite minimum viable product, but sort of the least amount of proof that will advance your concept forward. So if you said, okay, if I just got user feedback, and so kind of work with the people who are giving you kind of your initial informal feedback and say, okay, what's the next step? Will this impress investors for a round of funding? Will this be a nidus for a pilot project that can lead to a grant application? And figure out what point along the way is going to sort of replenish your fuel as you try and take it through that long road of whether it's going to be FDA approval or adoption. Whatever the long part is, identify the waypoints along the way and start as informal and as early in the process as possible. And that's a way to tap into some of the value that's sort of nested within both the DoD and the civilian healthcare system. Is, yeah, it's really hard to insert it into my workflow right now and expect me to use it, but maybe a little bit of informal pilot study, you can do some things with that. So that would be my advice.
Quick answer for us, it would be if it's a drug or a medical device, we have P&T and medical policy committees that have membership in the community and physicians that we have at Primera. And really, it would have to have gone through clinical trials and randomized controlled trials and got into either Cochrane or had a good health technology assessment say that, yeah, it's been proven to be better or work. And that's a long thing. We try not to talk directly to those types of innovators because we feel it should come out in the literature. If it's something that's not a drug or a medical intervention, then that's a lot more ad hoc. That sometimes we get connected with people and sometimes we don't. It's a lot more not as structured as the drug and medical device.
So I have a question. So do you view your organization as having a role in should you be expanding your role in the sort of innovation fostering process? And we've got venture capital, we've got government grants, we've got the other things that I've described. Do you see any other roles for innovating within what you're doing in terms of reaching out and kind of meeting people halfway, or is that beyond the scope of what you think your organization would do well?
No, we just divide it. So there's a part of the organization with an innovation lab and doing that sort of stuff, but the part that I oversee, the medical benefit and the pharmacy benefit side, really is trying to just limit it to things that have been proven effective.
realms of the best innovation that you've seen in the last year, and then give me an example of an area that you're looking for innovation in each of your realms that would solve some of your biggest pain points and make your life so much better.
So without revealing any proprietary information, it's a little bit hard to get into specifics of things that are still under investigation. We've had, so I'll give you, if I could give you maybe more just a survey of some of the ideas and some of the things that have been publicly reported. The sort of the app space is a really interesting market because the barrier to entry is often really low. The pilot studies are really not that onerous, and the amount of funding you need to move a study forward is not so great that you can't realistically find a smaller, maybe more rapidly acting grant. And so we've had a couple, so we have a program called the AMED, which is Army Medical Department Advances in Technology Initiative. And that's a grant program that we've gone to with a couple of different innovators in the Seattle area. With Tomorrow has a smoking cessation app where they use technology based on your phone to help with dealing with the cravings, and that's a project that we've been doing. Lightsprite has a stress reduction app that we've been working with, and so these are not necessarily game changers, but they address unmet needs in novel ways, and I like them because they let us innovate rapidly and partner in ways that we hadn't been able to before. But one of the things, and so I kind of harp back on this untapped potential. Some of the other things have included equipment that is protective against head injury, EKGs that go to the field in ways that other medical equipment maybe isn't designed for. And so night vision goggle assisted surgeries. There's a lot of ways in which our organization has kind of some unique niches that then we match up with another, an innovator, and find a way to test a project. And what I've gotten in terms of feedback from the innovators is, hey, sometimes just being involved in a clinical trial of some kind is enough to take back to investors and maybe get another round of funding, or to get more people interested in my project. And so it can be kind of a self-reinforcing and process that a collaboration begets the resources for the next round of collaboration. So those are some of the things that I would tout as successes. Challenges, there's a laundry list of times when we just couldn't adequately resource a study that looked innovative, and we just couldn't get it integrated into the workflow, or we couldn't get the providers to conduct the clinical trial. So I'd rather not go into the specifics, but there are too many to count, and that's one of the things that's challenging in our system, is trying to find ways to make those matches work, resource them when they need the resources, and lead to the innovation.
For me, there's two this year that have been pretty that I've liked. One I can't talk about, but it gets to making it simple and easy, and it gets to reading all the fine print of your health insurance booklet, and trying to find a way to make it simple and easy. So that was kind of impressive. It's not finished yet, but there's a lot of work being done in that. It's really difficult. The other one was the patient experience initiatives. One of them, if a patient leaves a primary care practice or a specialty practice, they get immediately, within 5 minutes of them leaving the office, a text message with 3 questions. And if all 3 are negative, or they didn't have a good experience, we're working with providers for them to respond to those. We also have it inside Primera, where if they call, they also get a text message. And if their problem wasn't taken care of, or they didn't have a good experience, we get alerted within the half hour, and someone can reach out. And then one that I think would be really good, which I think is already out there to some extent, is if you as a health plan person could know exactly on an app, where's your high deductible, just in really quick, easy to look at, where's your family's high deductible, so you always know if I'm going to have to pay a copay or a deductible, and that's just getting to making it simple and easy.
You know, I think we better call it at this point and move to the hospitality function. But this has really been fascinating. I find a lot of mental stimulation in this. First of all, we learned a couple of new acronyms, right? You got those? UDA, right? UDA. And DIUX. That sounds like an opportunity. But there's some gems in here about the fact that we actually have well-established case studies of different ways of paying for and operating healthcare. And when we have innovative ideas, there are places where we could find interested parties to partner with and to prove some of these things. One of my favorites that Phil alluded to is that the people who actually study international comparisons say that, well, it isn't just that the U.S. spends a lot more money on healthcare, it's that we also spend a lot less on social services, and that the evidence suggests that those two are strongly interactive. One of my hypotheses is that if I could figure out a way to remake, even at double the investment, the world of social work, I could probably get a 5x ROI in health cost reduction. I'm just as an example of we have narrowed our thinking in this country. We've screwed up the insurance marketplace. We're ideologically committed to markets, but we've got a bunch of stuff that's goofy, and it'll be interesting to see if we can figure out how to change it. But really effective innovations that demonstrate change will, I think, be what breaks this loose. So it's fascinating. Gentlemen, thank you so much. Before we break, let me also thank our sponsors. There are two, Cambia Grove, obviously, who is our host and our sponsor, but also the BioEngage program at the Department of Bioengineering at the UW is a co-sponsor of this series, and we're very grateful for that. So please, on your way to the refreshments, stop, join me in thanking our guests.
Thank you. Thank you for the invite.
Very nice, David. Thank you. Thank you so much.